Paul,
Present.
Mr. McBride,
Here.
Mr. Smith,
Here.
Mr. Garza, which I don't believe we can have him. Ms. Lee, I believe she's out as well. Ms. Smith,
Here.
Ms. Taylor.
Here.
Okay, I believe we have a quorum. Is that correct? I'd like the motion to approve the minutes from September 11th and September 23rd meetings.
So moved.
Second.
Okay. In reference to the minutes that we just said, I did announce at the meeting on the 23rd that I would be stepping down as chair. Therefore, we need to elect a new chairman. I'd like to put a motion on the table to open up the table for nominations for chair of the advisory board.
Reverend, this is Steve Capizzi. Sorry to interrupt. I think the board can certainly, the members can certainly do that. I think you could make that motion, but since that isn't on the agenda, it might be more prudent to put that on the agenda for next month. And it's again just a notice thing for the public, so they know that that's something that would be discussed during the meeting. Certainly, I don't know if that would be a requirement, but you know, in the spirit of that sunshine law, that might be something the board may want to consider. Is moving that to next month and then putting it on the agenda. But certainly, I think you're well within your rights to do it either way.
Okay, thank you, Mr. Capizzi. I want to state that a request was made. We ran out of time. So Penny, thank you for your diligence in trying to get that on. So I want to go ahead and still make the motion for us to have election of a new chair. Requesting that motion, please.
So I'm just gonna, I don't want it to be silenced. So I'm conflicted on the second. I want to just talk a little bit about this because I don't like kind of looking at this as the sunshine law, but I also know that for the reasons that the Reverend talked about last time, we do need some continuity in order to do this. So can we potentially modify this so that we can kind of do some nominations and then maybe finalize a vote, or maybe if we, how could we do a modified piece so that we have a way to move forward with some leadership pieces for the next month, unless the Reverend is also comfortable for his personal reasons in continuing to be our leader for the next month, because there, I want to respect his the communication he gave us last month, and also to make sure that we have some clear lines of communication in the upcoming month. So I don't want us to go 2 months in a place of, what are we doing, not doing, and I don't want there to be just sort of silence in answer to the Reverend's motion. So,
Phil?
Yes, please, Mary.
I agree with Spring, and I think, could certainly talk about this in new business, have a discussion about it, and propose that we put it on the agenda. I really do think we ought to have it on the agenda. I think when we elected you, Phil, it was on the agenda in our very first meeting. So I think it should be announced to the public and on the agenda, but I can't see that there would be a problem with discussing potential nominations during a new business section, as long as we're not making a motion or voting on anything. What do you all think?
I like that idea. Is that an okay compromise for you, Reverend?
I have no comment. let's move on with the agenda. There's a lot of business that needs to be discussed.
Phil,
Um,
could I just make one more request? Is my perennial request that the people, for the public who are tuning in, would the people in the room around the table please go around the room slowly and identify yourselves, your name and your role, please, so that the public isn't, and Mary are not in the dark. Thank you.
I'll start. I'm Valerie Nelson, Chief Operating Officer for the Healthcare Services.
Aaron Levin, Research Statistician, Justice Services.
Tina Johnson, Superintendent of Community Corrections.
Charles McKnight, Major Support Services.
Tricia Ross, Corrections Compliance.
Raymond Barnes, Department of IT. Major Jet, Security. Martin Howard, Deputy Director.
Doug Burris, Acting Director.
Tony Winberg, Change Management.
Penny Martin, Office Manager.
I'm Andrea Beam, County Data Officer.
And Reverend, I'm sorry, I don't mean to interrupt again. I hope I didn't come across as saying that the meeting couldn't go forward. I mean, I believe any one of the members, including you, can carry this meeting. A parallel situation maybe if Reverend, if you couldn't attend one of the meetings could still go on with a quorum of other members. So I hope my comments weren't taken as the meeting couldn't go on or the business of the board can't go on. It's just the mere selection of a chairman, I think, should be noticed up, or maybe more properly should be noticed up. So I hope that clarifies it, but certainly open to if there's any questions about that.
Duly noted. Thank you, Mary. I hope you received all the introductions. Thank you, everyone, for attending the meeting this morning. I'd like to go with, and again, without objection, we're going to hear from Mr. Burris. Give us a brief introduction as we start to go down per agenda items. So, Mr. Burris, I'd like to turn the meeting over to you to give an introduction, and then we'll go into the agenda items as printed.
Thank you, Reverend. I appreciate that. I've been here 1 month now as Acting Director. And before coming to the Justice Services Center, I had a career for 23 years working for the federal judiciary. The last 18 years of that, I served as Chief United States Probation Officer for the Eastern District of Missouri. During my tenure with the courts, I had a passion for working with jails, prisons, and correctional institutions. In fact, I was presented with the Correctional Service Award by Bureau of Prisons Director Harley Lappin, recognizing me for my work in successful recidivism reduction programs. Throughout my professional career, I have made a habit of surrounding myself with people smarter than me who share my dedication for positive outcomes, and I have a room full of people showing that I'm continuing that strategy. The results from teams I established have been recognized in such ways as as providing expert testimony on recidivism reduction strategies before the United States Congress, conducting multiple presentations at the White House, and serving on a 3-year think tank dealing with community corrections at Harvard University. I say to the board today that there are many issues that need to be corrected at the Justice Center, but I'm extremely confident with your help and direction, we can all together work and make this a benchmark organization for the rest of the country.
Thank you, sir. Thank you for taking on this challenge and position, and we look forward to working and supporting your effort and your goals and your vision. We'd like to go to item number 3, corrections medicine. Valerie Nelson, you have the floor.
All right. Good morning, everyone. So we'll start with the status of the COVID in the building. So the last update that I had sent to the to the board was on Monday, and we've had some results that have returned since then. And the latest information, again, related to just overall testing that is happening through the through the facility, and then an update on the transmission event that was identified in early October. So at this point, we have conducted nearly 4,500 tests throughout the facility since March. And we have a total of 89 unique individuals that have tested positive during that time. We do have about 130 results that are still waiting for the lab to return from our Tuesday test session. So I expect that number may change. But talking then about the transmission event that was first identified on September 2nd, we are now at 49 individuals who have tested positive, and that's out of a total of 124 that originally were housed in those general housing units. So the entire facility has been tested twice now, and we continue to move through our isolation protocols for all of those individuals. New housing spaces have been opened up so that everyone is placed into a single cell if that is appropriate for their security and health needs. And we have a series of clinical assessments that occur for each of these different groups. And I'll ask Dr. Doucette to describe what that looks like and the current health status of most of our patients at this time. But that is that's the overall status of where we sit. And I'd also like to take just a few minutes to explain some of the information that was sent out to the board earlier, just the high-level protocols that we have established here. And maybe Dr. Doucette, I will go through that after you. Would you like to talk about the current health status of our folks right now? And then I'll move backwards a little bit into that overview of the processes.
Sure. Yeah. I'll just touch on this piece briefly, and certainly we'll take questions at the end. We've certainly focused immediately on making sure that all of our patients who test positive for COVID enter care pathways that have a lot of immediate focus on tracking and monitoring their healthcare needs and making sure that we're responsive to them. So our current process is that all patients who are diagnosed are immediately assessed by one of our advanced practice providers. Develop the risk stratification system for patients based on what we know from about who might be at risk for more significant adverse outcomes related to a COVID infection. And so we are risk stratifying patients, and their care pathways are defined by that risk stratification. So clinical care for all of our patients who test positive for COVID includes very frequent vital signs, engagement with our clinical teams kind of at multiple levels in order to check for symptoms or changes in symptoms. And our advanced practice providers are seeing our patients kind of at intervals through that process based on their risk factors. We are assuring that somebody that as a patient gets towards the end of their illness, there is another check-in with the provider to assess for that clearance process, right? To move someone out of isolation who tested positive for COVID. So I feel really good about those protocols that we have put in place. I think that they're very appropriate and frankly exceed the level of care that someone would have in their home or in the community if they tested positive for COVID and were caring for themselves at home. So feel really good about that, and I think that has worked well so far. I will tell you that of our patients who have tested positive, the vast majority of folks are asymptomatic, which is really reassuring and also kind of aligns with what we know about outbreaks that we have seen at other correctional facilities across the country. So we have had a handful of folks who are symptomatic, but no one critically ill and no one who has required high levels of medical care outside of the facility. So that's very impressed with the work of our team so far and with the kind of collaboration between our safety and security colleagues as well as our clinical operations teams and our clinical providers. So I think that's a high level summary. And again, we'll happy to talk more into the details if anyone desires. So I'll pass it back to you, Valerie.
Any questions about the status at this point?
Valerie, I just want to make sure that we're very clearly stating the numbers once again, in that while we have had the asymptomatic cases at intake course of the pandemic since March, we are talking about the outbreak since the first patient we identified in general population on October 2nd, and the 49 cases have been since that case. Is some of those first cases that were identified, including that first positive case, are they all like recovered and through their full symptomatic cycle at this point? Can you verify that for us?
Yes, they've all, the original folks from the 2nd and 6th of October has been cleared and moved back to general housing. We were assessed by our providers throughout that time, and individuals covered and moved back.
I would like to recommend a modification then to the way that we're reporting for this particular outbreak, to talk about like an active positive cases. So those who would still be in their isolation period, and those who have moved through their isolation period or been released from isolation, so that we are being clear that we're not managing 49 active cases right now. There is a portion of those cases that we are managing right now, and some that have moved through that cycle and are no longer in an active infectious state, in an active symptomatic state, or or have any further outcomes right now, or are part of what you are trying to medically manage at the same time.
Absolutely, we can do that.
Reverend Duvall or Valerie? Can I interrupt?
Go ahead, Doc.
Oh, thanks. Yeah, so just so I'm clear on the cases, and I'm looking at the report that we got earlier this week, and thank you for your transparency and quick sending out of those results. So I'm hearing the report's at 81, but you're giving us a slight update to 89, and you're saying that there are 49 since the outbreak. Is that what you're saying, or 49 active cases? Is that what you're saying, just so I'm clear?
No, there have been 49 unique individuals related to this transmission event total. So they're not, I do not recall the current symptomatic folks or the current positives right now that are active. But the 49 is how many have been identified throughout this transmission event total.
Okay. Thank you. I think it's worth saying that out loud. And I do want to reiterate what Emily said, and just sort of, I think it's worth saying those numbers out loud again in public. And I think I do want to also applaud you for your protocols you put in place and to sort of get on top of this. And I've said it many times, and I was just reading a story online about the outbreaks in prisons in Missouri, statewide and nationwide. And although any cases above 0 is not what we want to see. So this is unfortunate, but this is the first outbreak we've seen in the jail, as far as I know, within the jail. We've had some people come into the jail with COVID, which is not surprising given the climate outside the jail. But the number I just saw in a story I was reading from the last 24 hours is there's over 1,300 cases in Missouri prisons, and there's 7 deaths now recorded, but I don't think they're even reporting numbers statewide now. So 2 things about this is, these should all be put in context, that you're reporting these numbers transparently all the time. So you shouldn't be, you should be applauded for that, not criticized. And you should be, and it's good that these cases are asymptomatic. So that's much appreciated and should be put in context. Thank you.
Phil, can I say something?
Go ahead, Mary.
So I continue to be impressed, as always, Valerie and Spring and Emily, about the response in the jail. And you know, as someone who's been only too open about my criticism, it's really important that people know, I think that the public know who are listening in, that it was 6 months with absolutely no community spread. The only positives were people walking in the door, and that you had a plan already for that. You hit the ground and it contained. So my first question is, do we yet have any clue about contact tracing or any kind of clue about what caused this? Is it, I mean, since it wasn't new people coming in, we assume, was it staff, or do we know where it came from, and do we have any hints about that? And I'll let you answer that, but the second thing, I should have said this up front, that the other thing that I'm most impressed with is, this happens to real people, not just numbers. And I think your corrections medicine community liaison program, where you're reaching out to families of people who are in isolation and providing them extra phone calls and contacts with their families, it's just worth saying out loud again that we are, that I really do think you're seeing these people as patients, which is human beings who have families. And I'm really so grateful to be, even closely connected to that. But then can you tell me about where we think this came from?
Dr. Doucette and I have been working with our communicable disease team at DPH for weeks now to look at exactly what that is. So the way that we approach that is, in general, anytime that we have had a positive here in jail, then I do essentially an internal contact tracing through our data systems, because we can tell who has been around whom. And that then was the input, about half of the input into the contact tracing approach with our communicable disease team. The other half was to look at staff that has been ill or tested positive from our department. And that is the less complete information. But Dr. Doucette, can you please expand a little bit more from your perspective of the clinical contact tracing and so forth, and where we go next?
Sure. Yeah. So what I will say is that we are doing case investigations and contact tracing based around the clock and for the better part of this year. I will say that it's clear that this event is, as we expect in kind of congregate living types of settings, is complicated. And it is, we can't say with 100% certainty, this was patient 0 or this is kind of where that event moved from. I do feel very, very confident in the kind of mitigation strategies and the prevention work that is going on in the jail and kind of how we have managed that movement. I think that the reality of the situation is that all of those pieces can be put into place, but there is still no way to completely manage any level of risk of somebody who is asymptomatic entering the facility. And so certainly that is the likely place that we have seen, that the infection was brought into the building, and it does not seem that we will be able to pinpoint that to a specific event, unfortunately.
Okay, I can live with that mystery then. Okay, thank you.
Mm-hmm. Yep.
We're not living with it quite so well.
Easy. Well, I mean, the only reason would be, if you knew how it came the first time, you might know how it comes in the second time. But
certainly,
other than that, I'm not worried about going back and raking up old things. Only if it informs what we're doing going forward.
Right, and we've certainly looked at. Oh, go ahead.
I was just gonna say, if we could have identified sort of that like a specific source, we would have made that sort of a part of what we were explaining to people. We don't have like an explicit source. I would also just point to, this is an astronomical proportion of asymptomatic positive cases in comparison to what is currently known as asymptomatic potential populations in the general population, which gives us a lot of concern about the overall scope of the pandemic, but is the most likely cause of it almost has to be someone with access to the to external community sources of transmission. But if they were fully asymptomatic through that entire time period and weren't tested within the small range of time during their viral cycle that they could have been tested, even if we tested them a few days after that viral cycle, the test would not pick it up necessarily as being like a potential source. So there's a timing factor in that, as well as the way that the virus transmission works. It nearly has to be an asymptomatic person with access to the outside. We just can't specifically identify whom.
And in response to that kind of being the end of our information to have confidence in, we then have taken steps to all along the staff in the facility have had access to no cost and rapid results if we choose testing at DPH. And we encourage that. We have communications that go out every week to encourage folks to take advantage of that. We have also held sessions on site here at the jail for employees to have that testing conducted, and those will continue as we need. And there are other options through DPH as well for folks if they choose to not take advantage of that here on site, but we have other locations throughout the community too. But we're always encouraging folks to take advantage of that resource for themselves, for the facility, for their families. Okay. All right, if it's helpful, I can give a high-level overview of really what those protocols are for the facility. If that would give everyone a little bit of an idea of what a patient experiences as he or she moves through, would that be helpful?
Valerie?
Yes.
May I ask a quick question based on what you and Spring have shared so far?
Sure.
And this really isn't specific to the jail, but my question is, insofar as what you all have described suggests a much higher rate of community spread throughout the region, are you guys, and obviously Dr. Garza, is part of our board, but are you guys having a chance to talk with him, kind of outside of this venue, to share your findings with him that could, hopefully inform his recommendations?
Dr. Doucette, you're probably the best one poised to answer that.
Sure, absolutely. So the Department of Public Health, our other regional health department partners, as well as members of the hospital systems and pandemic task force are in regular communication. I would say that Spring or I or other members of our leadership team have at least, 5 to 7 phone calls or other conversations with that group every week. So certainly we're very linked and working together and kind of sharing our learnings. I will say that the experience that we have seen from, we have some, kind of listserv collaborative communication with other jails nationally, and some of these patterns that we are seeing with this outbreak really mirror what some other folks have seen of these very high levels of asymptomatic patients and that kind of pretty quick spread with high attack rates. I mean, it really is relatively, that pattern does seem to be kind of emerging in regard to jail and prison outbreaks in specific. So,
okay, thank you.
Mm-hmm.
We've had some good conversations about our concerns for what that means for our assumptions about what's happening in the community, because we do not think that it is this high asymptomatic with this high of an attack rate because they are in jail.
Right.
We think that, but that would mean an extremely high proportion of community members right now that are asymptomatic positive cases.
Right. Yeah.
So, yep.
Okay. Thank you.
That's uplifting. Yeah.
Yeah.
Go ahead, Valerie. Go ahead, Valerie. Please continue.
Sorry about that.
All right, it looks like we were muted here on our end. So I will give a brief overview of the pathways and the protocols that are established here in the facility. And Ray, if you can go to the one that's job aid A, please. Thank you. All right, this is just a visual of the flow that patients will go through as they enter the facility and go through our quarantine process. And there is essentially a happy path, and there is a path where we will quarantine or isolate folks. So starting at the top left, this is the entry that every individual coming into the facility who goes through our intake process, they are assessed for a variety of medical and healthcare needs, mental health needs, and the COVID screening and symptom assessment is part of that as well. So this, again, is every individual coming through the facility. If that individual is assessed by our clinicians to not have any COVID symptoms, then he or she will proceed over to that middle section that says phase 1 COVID protocol. We have quarantine units that all individuals will be placed in for approximately the first week. They receive a test at that time, and assuming that that test is negative, then that patient would move on over again to that top right space there. That is our phase 2 quarantine protocol. So that's a different housing unit. The patients are tested again and reside there for approximately a week so that we end up with a 14-day quarantine for everyone coming into the facility. After that criteria has been met, then that individual can be placed into the general housing units based on standard security protocols. If at any time the patient presents with symptoms, then they are moved to our COVID housing unit. If at any time the patient tests positive, he or she is moved to that COVID housing unit for isolation. If those scenarios do exist, if they are presented, then the person's cellmates, and that's, we go through an internal contact tracing process here to make sure that we can identify who may have been exposed to either of those folks. And those exposed individuals are also monitored and tested and quarantined until we've proceeded through the CDC recommendations with testing and so forth. And then at that time, once they're cleared, then they can move on into general housing. All right. Questions? All right. The other quick view that I wanted to share with you all is, Ray, if you can move over to the one that is labeled Job Aid C. This is kind of a list of rules that both of our departments operate by when we are caring and providing security for these patients in the COVID-related housing units. So there's a lot of information here that I certainly will not go over, but the intent is to share with you that we have established classifications, designations for people in these various phases so that our departments, the staff know that at any time when they are caring for or providing security for any of these individuals, they can be aware of what COVID-related cautions we need to follow. So there are, it's an isolation, it's a quarantine set of, or approach, I should say, meaning that then will guide other operational activities in the facility. So the general idea is that during the quarantine phase, and if someone is isolated, that the activities that they, that normally come to, the activities come to them at their cells rather than having a lot of movement through the facility so that we can minimize that exposure. And we are, again, I think I stated that we're moving everyone into single cells as much as possible so that they can have that level of comfort as well, and that we can better manage that transmission risk. So folks are moving out into that daytime area in small groups. There are, so that the security teams can manage social distancing with them. All right, questions? All right. Then should we move on to the operational metrics for corrections medicine?
Yes, please.
Thank you. That will be the dashboard.
First one.
Second one. All right. There aren't a lot of metrics to point out here as anomalies this month. So in general, what is happening is that, again, our providers are going to our patients rather than having the patients come down to the clinic. And so that's an attempt, again, to minimize transmission and minimize that risk through the facility. On the first page related to our safety metrics, we've seen a little bit of an increase from last month in folks that have gone out for medical care, but nothing that's alarming. Again, we do have our standard consultant specialty care processes that have resumed. So we see some activity there. Then, let's see, moving on to the delivery metrics. The main metric that I would point out here is related to the last one, with the number of persons with a psychiatric visit in the infirmary. We have had we've identified a data capture, a documentation error, that we have a new advanced practice practitioner who is a nurse practitioner with a psychiatric specialty who joined our team. So we're very grateful and happy to have her on the team. We also then realized that we did not have her profile set up correctly in the EMR, and so we missed some data there. So that's where we see in this last metric that looks like the visits were down, but they're actually not. So that's now since been resolved. And then, Ray, if we can go to the last page, please. As I said, the rest of the metrics really are quite stable, and so I think the next point that we could talk about is the staffing crisis, honestly, that we have in corrections medicine right now, and that will really kind of lead into the update that we can share around the strategic planning subcommittee that we met with last week, I believe it was. Mary, you may have to keep me honest. But we've talked here in this audience for several times that historically corrections medicine has had a real challenge in maintaining staff, first in finding staff, the clinical staff, and then maintaining it and protecting those colleagues here. And that's due to a lot of variables that we have made a lot of progress on in the last many months and time as well. But we are seeing a significant exacerbation of the staffing gap, and we really are at a very critical point at this time. So we have been brainstorming to think about what do we do in response to that. And Dr. Doucette, I might again ask you to help support the background here with some of the steps that are being taken at the county level to help support that. And then we can get back to next steps that were related to?
Yeah, and we did just kind of want to bring up in this forum and make our board aware that while chronic understaffing is always a challenge in our environment, we are certainly at a really critical place. As a result of multiple factors, but the increased care needs associated with not only testing and screening for patients who may have COVID-19, but also the care delivery associated with that group really is just kind of this addition to our system needs that were previously unexpected. So we are really aggressively looking at not only, so we've been working very closely with our county personnel colleagues to look differently at some of the options for hiring of practitioners. We also are looking at several procurement opportunities of different types of licenses of professionals that we have not used in this environment in the past, particularly professionals like paramedics or EMTs. So really we are, what I would say is that we are blowing the door wide open and really thinking very differently about how we can solve this problem, because unfortunately, clinical staffing shortages pushing a lot of healthcare delivery, a lot of healthcare facilities at this moment. It's a pretty unprecedented time, and that's just kind of impacting us at this additional level and putting us at some risk. And so we are aggressively looking at that, and we'll continue to share what some of those models look like as we build them out in the coming months. But it is top of priority and top of mind. So,
Reverend Duvall, could I ask a question, Emily? Or
go right ahead, Doc. Go ahead, sir.
Thanks. Appreciate that. And, just even though I'm a statistics person, I appreciate the dashboard all the time. I definitely do. So just to make the 23 open positions real so that we can get some context for that, can you just give us some and I assume this 23 open positions are in the health side. We haven't had the correction side yet. So can you tell us what this means in terms of real staffing or real does it mean that there are shortages in terms of not being able to offer hours or visits or testing, like you said, or do people have to work overtime? Could you give us some context?
We have not reduced any services. It means that we have twice. We are currently in one now that implemented a mandatory overtime for, I should also say, Dr. McBride, yes, the numbers that I am speaking of are entirely on the corrections medicine team. So but we are currently in a mandatory overtime, and we're in the second month of that now. It's quite frustrating for the staff, obviously. And really what happens, because we have some very dedicated colleagues, and they are working very, very hard to try to accommodate those gaps in shifts, and we absolutely appreciate that, and it's been critical, but it also means that we have a small number of our colleagues who are working really an unsafe number of hours for themselves, and it also can present a patient safety risk because of just that fatigue. And it really is at a point that it cannot continue like that anymore. So these 23 are entirely on the clinical side of the corrections medicine department. And, it means that folks are coming in on a regular basis every day to their shifts, and they're moved around to the functional areas that we've had call outs in or just other gaps in work shifts.
Thank you. That's helpful. Well, and it means not only potential safety risk to them and others, but cost to the county as well.
Yeah, and we have, to tell you of kind of the personal effect of this, we have a few of our colleagues who are literally working we're 24/7 operation, obviously, and they are filling in gaps in shifts one day during the day, the next overnight, the next in the evening, and it's really, really challenging, and it's simply not sustainable.
Thank you.
Phil, if I could.
Please, Mary.
Ray, could you go back to the patient safety slide, the one where patient safety events, sentinel events, morbidity and mortality, I think they're all on one page. And I'm just going to make some comments for the record. We have a really long agenda, so I'm not going to go into detail, and I don't think we need a discussion about this unless other members have questions too. But just to let you know that Valerie and Alex Garza and I did meet for our first discussion about a strategic plan for corrections medicine. And so Valerie and I anticipate that a lot of these things we'll be putting into that pot and discussing later on, but I just want to mention them for the record. And I appreciate your glossary of definitions, but I would make just a couple of questions. I think it's the next one down. Or maybe it's, oh, there it is. There it is. Good. Great. That's it. So just a couple things about a definition of patient safety event, because that isn't in the glossary. And I know this is a fairly new thing within the last 6 or 8 months that you're looking at this differently and having it reported differently. But at some point, I think we're going to need a little more granularity about what the patient safety events are. And we can, again, that's part of our planning, because the data is only interesting to me if it raises questions that we can do something about, right? If we can't do anything about it, I'm not interested. And so to know what the patient safety events are is helpful. To see them over time is helpful. The high level view is good, but some granularity, and I know that's going to make the county counselor's office nervous, but we can do some of that in closed session. I'm fine with that, even though you know how I feel about closed sessions. But anyway, I think we need some granularity on the issue of sentinel event. I think it's important for us to know what they are. You do have in the glossary, you do have a definition of it, and it almost completely mirrors the commonly used term never events. But I know you're looking at all deaths or serious morbidity as well as mortality. But I'm concerned about the sentinel events, because sentinel events are typically, and Valerie, you may know this, they're not represented in percentages, because they're considered never events. So, and they're considered preventable. So the raw number is the important number, I think, and I'm glad you have that there. But I don't want people to feel comfortable, as people early in the patient safety movement did. They looked at percentages and said, hey, well, we're doing it pretty well most of the time with sentinel events. But these tend to be, wrong medication causing death, or, in the medical world, operating on the wrong body part and stuff like that. So 99% isn't good enough for any of that. Only 100% is good enough. So we can talk about that. I think it would be helpful for us to know when there's a sentinel event and what it was, just to get kind of the long view about whether or not the things we found during some of the death reviews continue to be sustainable, whether some of the changes that were made are in the long run doing well. And then as to the M&M, I guess I assume that's a morbidity, not a morbidity review, not a mortality review, since we didn't get notice of a death. And it would be helpful. I know that this is touchy too. I'm an old healthcare lawyer, so I get the issue of confidentiality and not revealing these things. But again, for the board, it would be helpful to know if you found it important enough to do a morbidity and mortality review, not with details, but what did you find that you learned about? Are you doing anything different as a result? And those are my only comments about the medical. But and we can just tuck that away, Valerie, for further discussions, if that's okay with you.
Certainly, I think we're capturing the information that you referenced, Mary, so it's a matter of, communicating that in an effective way.
Well, and, the purpose of communicating it is so that we might have some, it's not just one-way information, as you know. I mean, this is, when we take the long view, it may be that we're doing better. It may be that we find some things that aren't doing so well. It may be that your reporting culture isn't what you want it to be yet, which is another issue that we talked about. You might want to try something else, because the question is, have you had any surprises in terms of complaints or lawsuits that you didn't have reported in a patient safety event? So the question, is anything going below the radar? That's my question. And I know these are all controversial questions, and that's kind of my bread and butter. So we'll talk about that later on, if it's okay with you, unless anybody else has any comments about my comments.
Very well. Valerie, do you have any closing comments?
Only to ask for a discussion of next steps on what we would like to do about looking at the standard communication model that we first introduced last week. If we want to take that offline and review those and come back next month to agree on what will be beneficial to everyone, or if there are other steps to look at adjustments right now.
I'd like to take that up to the next meeting.
Maybe we can do some discussion in between the two meetings if anybody else wants. I know Spring has some ideas about this too, but maybe we can do some work on it, so what we bring to the next meeting has some a little more form to it. Is that okay? I'd be glad to work with you. I think that's part of that strategic plan. I'll be happy to work with you on that, Valerie and Spring.
Yep, I'm in.
Thank you.
Okay. I have a quick question, Spring, Dr. Duchette, or Valerie. We appreciate the updates, and we definitely appreciate all of what your team has been doing and continues to do. Is any of this information, any of this communication being given to the Public Health and Safety Committee on the County Council? How informed are our County Council to this information that we're receiving?
So we do, after we tell and make sure that the staff are aware, we tell all of the board members. After we have told all the board members, we prepare a what we're calling a media advisory or press advisory. The council members are all included on that communication. So people who sign up for the regular updates that we send out, like sort of across the department. So members of the council would also get that email at that time too.
Is there any response, or is it just an email and that's it? I mean,
it is an email. We haven't had any further sort of queries or sort of questions in that space from any of the council members.
Okay.
I
Thank
also
you.
meet with the chair of that committee about once a week, and we present to council members, like in the oversight committee, from a care standpoint, in a separate meeting as well.
Okay. Thank you. Mary, I think there's going to be an opportunity for the advisory board maybe to weigh in. And again, I appreciate all the other presenters. We're going to move forward. I think I just want to make the statement that Valerie and Dr. Duchette and Spring, your work does not go unnoticed, as you will see when we respond. But it's imperative for the community to hear with some context just how much you guys are putting into this and how much you're proactively sharing the information and trying to bring it to a more manageable, substantive way. So I make no apologies that we do spend this much time on something as serious as correction medicine, and especially all the efforts needs to be put out there in the public space. So we're going to continue, and I hope whoever takes the chair position keeps that in mind, that these are, as we know, a deadly pandemic. It affects the inmates, the families, not knowing what's going on with their loved ones, and the safety of everyone involved in the correctional facility. So that should be noted. So if there's anything else you'd like to close on, Valerie, I'm going to go ahead and move to the next item.
No, thank you, everyone.
Okay, thank you. We'll ask now for the dashboard from Justice Services.
Ray, do you mind if I get that roll around? Thanks.
You may have to move that speaker.
Yeah, where do I? All right, hi everyone. Updates on the dashboard. So just an update. Tricia and I met with the data subcommittee a few weeks ago to discuss both some stylistic changes and some substantive changes or updates that we want to make to the dashboard. I've incorporated the stylistic changes to the new month's dashboards. We're still working on figuring out just exactly how and what we're going to be able to do from a substantive perspective to make these better. So for now, these look the same more or less as they did a month ago, but just know that we're continuing to work on that, and we'll be coming up with improvements as best we can in the near future. So for each of these, I've just added the data. I don't know how, I won't go through all of them, but I've added the new data for the month of September. Once the month of October is done, I will add the new data for that as well. Most of these bookings and releases and population data and such are, excuse me, are measured on the monthly level. The one exception that I wanted to talk about, I think Mr. Burris wanted to have a discussion about this afterward, but is the daily population. I've actually updated this so that we can see the daily population log through today. So we see through the end of September is where it ended prior, but this was about 842 inmates right around the end of September. And as of today, the count is 909. So we'll get into that more as we talk about the jail census, but I just wanted to note that this is the one that I updated specifically to get come through the data all the way through today as opposed to just through the end of last month. The supplemental dashboard that contains some of the other data. Dr. Garza had suggested standardizing these metrics to the per 1,000 inmates rate as opposed to them being just counts. So we have updated these accordingly so that these are rates as opposed to counts. But otherwise, these are the same figures: use of force, hospital posts, social and professional visits, and ER runs. And I've standardized those to 1,000 inmates and updated them to go through the end of the month of September. Once October is done, I'll update those accordingly, and we can look at the October data in the following board meeting. So I don't need to go into any more details unless anybody has any questions about any of the specific dashboard windows, either on the main one or on the supplemental one. They look pretty much the same as they did last month. Like I said, we're still working on figuring out exactly what we can add to improve them. if we want to dive in a little bit more to this discussion about the daily population, we can do so as well.
Reverend Duvall?
Yes, go, Dr. McBride, go ahead, sir.
Oh, thanks. And I just want to applaud you again for all your hard work and a very quick amount of time in putting this dashboard together. And we did meet as a group to discuss changing these metrics. So I appreciate your changes you put in place, the per capita changes. So thank you for that. So I think that does help on that graph that we're seeing on the upper left-hand corner. That sort of gives us some context on that with shifting population sizes. That's important. Yeah. That's why we did that. Back on the population counts, I think it's also, or the daily census, if you could throw that up. It sounded like Acting Director Burris may want to comment on this as well. We had talked about this last time, and the yellow line, I guess the yellow indicates after the COVID, is that one?
Yeah, the scan is since mid-March when COVID really hit hard.
Yeah, so we had talked about this last time, that sort of this U shape to this is the uprise in that is reflecting, as I understand it, the slowdown in the cohorts from inability to get people through their cases, so they're staying in the jails longer. Is that correct? Not an increase in crime in the county. Is that correct?
Well, it could be both. I mean, I know we had discussed that possibility about the slowdown in the courts prior to this, but we also noticed that we keep track of the more minor, the C, D, and E class felonies each week, and when we go through the data each week, and we noticed that though those have been going up a little bit, they haven't been going up enough to explain the total increase from in the last few months. That's where it's really gone up rapidly. So we're thinking that it's a mix of a small increase in the more minor felonies, a possible slowdown in the courts, and also somewhat of a sizable increase in the more major felonies too. More people coming in with.
We're getting areas that I can say we get more low-level arrests in too. So.
And more low-level arrests. Yeah. So I think it's honestly I think it's across the board. It sounds like I think it's more high-level arrests, more low-level arrests, and a slowdown in the courts. A triple whammy of all three.
Right, Dr. McBride. This is Doug Burris, and additionally, Aaron shared that we have 909 people in currently. 115 of those are federal detainees, and that is a number that's gone up 18% in just the last month. So that's one of the things we're working on. And one of the things that we're also trying to implement is doing risk assessments on all of the people to share with the courts. And if there are any low-level people based on the risk assessments, hopefully we can move those people out quickly.
Thank you. That's very helpful. And all this, and I get teased by this by some of my colleagues because I often start a sentence by saying, as I tell my students, as I tell my students, the answer is almost all the above. So it sounds like the answer is all the above, but so it's an answer of, you just said it might be 3 different causes, but it's really important that when people see a line like this going up, that we understand there are multiple causes for this, some of them related to the COVID-related slowdown in the courts. It's what we kind of heard last time. So, one way to get at that causal factor, could be the arrest records if somebody wanted to dive into this, but also we have a metric on there, a chart which you could put up on length of stay in the prison, right? In the jail, I'm sorry.
Yeah, I'm working on it.
Okay, so that would get an indicator of how long they're waiting on trial. Yeah.
Yeah, you can see maybe with a little bit of a normalization this past September. The last few months before that were real high in comparison to historical.
Yeah.
So.
Thanks.
Mr. Chair, if I may.
Yes, ma'am, please.
I want to, we did have a really robust discussion, and I know that we gave like a whole bunch of notes because that's what we do here in looking at these dashboards. And I know that you're still working on a lot of the metrics and how to incorporate many of these things. And it's good to see some of what we already talked about in here. I think I want to point out that one of the things we talked about at some length in our data meeting is that it's important to have these demographic pieces as an important discussion about who we are looking at, like within the facilities. But that we do have a few concerns about the fact that most of what you're looking at demographically here are not things that the Justice Services Center has control over affecting. And that's something that we actually spent a great deal of time on. So it's important to understand the population that we are serving, but it's difficult to turn these into performance metrics as opposed, and so we don't want them to be seen as performance metrics of Justice Services. These are more like the demographics of who Justice Services is serving rather than, kind of opportunities for quality improvement, since Justice Services has no control over, for example, the average monthly length of stay for their inmates in these various categories. So it's an important context, but it should be seen by the members of the board and others as really largely demographic information. And we had a lot of robust discussion, and I'm sure that we will continue to do so on where Justice Services has opportunities to present performance metrics. And I think the supplemental dashboard has more of that. So those are things that involve the actions of Justice Services. In like for the hospitals post and ER runs, it talks about the engagement of their staff in some of the medical issues and the hours and things like that. Certainly use of force incidents is a reflection of things that Justice Services is actively engaged in. Social and professional visits, again, this is something that Justice Services is doing. So this is the area that we are particularly interested in building out a more robust reflection of what are the performance measures of the Justice Services staff in serving that demographic population. We want to know that about the demographics, but we also want to know where those opportunities for improvement are on the kinds of things that Justice Services is doing.
Phil,
Excellent points. Thank you.
if I could make a comment on that, I understand what you're saying, Spring. I will say though that if we stop looking at all the departments within the county as separate silos, sometimes the demographic, and I'm not saying case, but if I think the demographic information, for example, the length of stay is very interesting and actionable, I think, within within the criminal justice system. And I think the number of people who are there on technical parole violations, we've talked about that in the past, that has really gone down. And so I think that's informing the community. It's also informing other members of the criminal justice community. The other thing is, I think it's real, even though I look at the slides on racial mix and I look at the proportion of Black males as opposed to white males, and I know that I can't do anything about that as a board member, but boy, do I think that's important for the rest of our community to see reflected, to see the evidence, and to perhaps inform policing or inform somebody else. But when I see that, almost like between a 4 and 5 times increment, if my numbers are terrible, so don't go with me, but the difference is huge. And so while I think it's not actionable for us, I think it's actionable for us as a community. And I think it's important to have it out there and have people be reminded that Black men are not just overrepresented, they are majorly overrepresented right here in Clayton. So that's my little, that's my sermonette for that bit. Okay.
Oh, I absolutely and wholeheartedly agree. These are public facing information. It's absolutely critical for us to understand the population that we serve, for us to be having bigger conversations in the community and justice and public health to also be fostering some additional community conversations. I just want to be clear that it's difficult to be taken as a performance metric of the Justice Services Center. That's it.
Duly noted. Any more questions for Aaron?
Thank you, Aaron, for your hard work.
Thank you.
And I appreciate the patience. The demographic information is easy to compile and display quickly. The supplemental information that deals with the programmatic angle of justice services is sometimes not as easy to get your hands on quickly and not as easy to display in the snap of a finger. So I appreciate the patience as we work through getting more of the supplemental metrics and more of the metrics that are within justice services control displayed on this dashboard.
So do we track use of force and what types in terms of how many restraints? Do we track that data?
Yeah, that's split up in this dashboard here.
Okay. All right. Thank
These
you,
are broken
sir.
down by restraint chair, pepper spray, and taser. That's on this dashboard.
Okay. Thank you.
Sure.
Mr. Burris, we'd like to go to jail census status, please.
Aaron did a pretty good job with that, Reverend. We do have 909 people, of which 115 are federal cases. The gender breakdown is males are 857, females are 52. We are seeing increased numbers across the board, as Aaron pointed out. We are seeing some petty increases that luckily are getting out. I mean, we've had someone bonded, was arrested and brought here recently for a broken windshield, and I'll be reaching out to the chiefs of police of any departments that have a pattern of doing this.
Thank you, sir.
Director Burris or Reverend Duvall, can I ask a quick question?
Go ahead, Tim.
Yeah, so I'm curious, and again, I'm somewhat of a newbie in understanding this. The 115 federal cases, what's the story behind that?
There has been a major push by the United States Attorney's Office in this district to go after gun crime, and they have actually deputized state prosecutors as federal prosecutors to bring those cases to the federal system. And that's really, I think, largely, probably completely responsible for the uptick.
And when did that start? And then when did it start coming into the county jail?
It started approximately 4 months ago, and it's been filtering in ever since.
Okay. And are they all going to the county jail, or some of them going to city jail and other places as well?
The U.S. Marshals are responsible for the custody of these defendants, and they are going to facilities throughout the area.
And do they stay here for a while and then go to prisons, potentially?
Yeah, the 85% of the people charged at the federal level historically have gone to prison that have been sentenced in federal court. But I think the majority of these cases are perhaps even looking at mandatory minimums. So there's a higher likelihood of them going off to a federal prison.
And Dr. McBride, I want to chime in a minute, Darby Howard, but our maximum capacity for federal inmates is 120. That's what we allow to hold for the federal government, 120 of their detainees.
Very interesting. Thank you.
Reverend Duvall.
Yes, please.
Okay. Director Burris, how many people, so that's the census count. How many people are being surveilled electronically?
Oh, do we have that data?
For
Yeah.
marginal monitoring, 1,200.
Okay.
I don't know about ankle bracelets.
For which monitoring?
Marginal monitoring, we have 1,200.
Okay. Okay. On the EHOC, we have approximately 1,200, And Mr. Smith, I do not have the data on the ankle bracelets, but I'll be sure to have that available at the next meeting and send it out prior to that.
And what is the status? I know that was like a pilot program when instituted. Do you know, are we going to continue that? And kind of where are things?
We have every indication that we are going to be able to continue it, and we have it budgeted. And so I don't think that there's going to be any worry about not having that as an option.
Okay, that's good. That's good. Okay, great. Thank you.
Our next agenda item will be on the use of force.
Thank you, Reverend Duvall. In the interest of time, I'll give a very quick summary here. I think our current use of force policy is a very traditional correctional model. When someone starts becoming a threat to themselves or other, we issue commands. There's not a whole lot of emphasis on soft skills, verbal skills, trying to talk the people down. The correctional models typically are issuing commands under the threat of punishment. And I think Dr. McBride could probably speak to this better than anyone, that that's not the most effective method to get compliance. And there is a program that was developed that's being seen as best practice out of Nashville, where it is all the focus on soft skills, verbal skills, interacting with the people, trying to get dialogue going, rather than just issuing threats that are going towards possible use of force. And we had two of our staff, Chuck McKnight and Paul Jett, go to a Train the Training seminar on this, and they're going to briefly present what they found about the program.
Good morning. So, you know, like Mr. Burris said, we felt there was a need that we could better enhance the way that we respond to problematic behavior within an inmate population. And this training here focuses more on confrontation avoidance skills versus, you know, the old use of force continuum where there was less communication and more just directives and getting right to the next step if that didn't work. So during this process or this practice, you know, during the communication part, you'll try to get to the root of the problem, and maybe it's a mental health issue, maybe it's a medical issue, and you can really get them departments involved in de-escalating the situation before you have to go to physical control. And if you do have to go to physical control, it's a less constrictive way of dealing with the inmates and the use of force. Major Jett?
Thanks for going over to me.
Yeah.
The biggest thing that Major McKnight focused on is trying to draw in caseworkers or healthcare professionals on the mental health care side as well. We have always been where the officer on the scene tries to talk to the inmate. They'll call the supervisor, and the supervisor will try to talk to the inmate. We haven't been known to bring in the mental health workers or caseworkers who may have developed a rapport with certain inmates. So those are good options to have, rather than going straight towards you need to cuff up and placing them in a chair for a timeout. This is going to give us a few more options and try to work with the inmates and de-escalate the situation.
I believe that we've sent out the policy that they use at the Nashville jail, and I brought this up looking for advice from the advisory board if this is something we'd like to perhaps implement. It would require significant training, and I think it'd be really important to do this at the recruit level too when new employees are coming in, and make it part of the training as well. I just think that by doing this, we would see the use of the restraint chair, the potential for injury to residents and to our staff. I think all of that would be reduced. And frankly, I think it's just a more humane way of working with the clients that we serve here.
So what I'd like to do is, we appreciate the emails. Let us go ahead and review it, and we'll have more further discussion in the next meeting. So Penny, will you please note this, that this is something we'll want to follow up in next month's meeting. Thank you, Major McKnight, and thank you, Major Jett.
Oh. All right.
Okay, go ahead, Mr. Burris, you have the floor, sir.
All right, next up we have about the food contract with Trinity Services Group. We've had some issues with shortages, both in supplies and food. With the help of our procurement and legal departments, I sent a notice to correct a letter to the corporate office at Trinity. 3 days after they received that letter, Matt Stimpson, their regional vice president, flew in from their corporate office in Florida and met with us. We had a lengthy and I thought extremely productive meeting to correct these issues. They were getting a count of our census and then making food based on 3% over that. They have immediately changed that to 8% over, which should help with or hopefully eliminate the shortages on the food. And they've also have arranged with one of their vendors that supplies equipment and food to do emergency deliveries as well. I think it was an extremely productive meeting. I believe that they are dedicated to making this right. And I'm not just basing this off the meeting, but the fact that when our staff went to the Nashville jail, Trinity is the food contractor there, and Officer McKnight, Mr. McKnight, talked to the staff there about their experiences working with Trinity. And would you share what that was?
Yeah. So they were very pleased with working with Trinity. I know we had the opportunity to eat in their staff dining area, which was a cafe there, and food was very good. The inmates seemed like they enjoyed the food that they were being served and the quality. So I think that Trinity is capable of providing us the same quality as they are doing in Nashville as well.
I should also add that they are in the process of implementing the vocational training program that they had talked to us about previously, where the people that work, the residents that work in this program, making the food and everything, they'll have a formalized training program where they can get 2 separate certificates. One is in food service. We'll have all the testing that needs to be done, everything set up for them when they're released to obtain a job, and they actually have a management program for the residents as well that they'll be training on, and it's a certificate-based program as well.
Okay, Mr. Burris, just a brief suggestion. And again, thank you, Major McKnight, for that testimonial of what you observed in Nashville. We may want to consider, since I know there's been some concerns about seasoning and diet restrictions, let's find out what they're doing in Nashville relative to how they're handling the seasoning of their food. And then possibly let's get a list of their menu items just so we can do a comparative as to why their food may, they're ordering, so forth. Let's just try to take a look at that and then kind of make some comparative when going forward with the food service. Just a couple of suggestions.
That's an outstanding idea, and we will get that done.
Thank you, sir. Employee and volunteer surveys?
Well, we'll start with the volunteer survey, Reverend, and Andy Beam and Mary have been working very hard on getting this survey to send out to the volunteers. We haven't been able to utilize them because of the COVID outbreak, but we want to gear up. So on the day that we have the authority to do so, we will start utilizing them again, and we would like to make this program bigger and stronger. There were some restrictions that were placed on volunteers and people eliminated from the program previously that I think were areas that we don't want to go with our program. We'll change those up. But it'd probably be best as far as the actual survey to have Andy Beam explain what's going on with that.
Thank you, Director Burris. Can I have permission to share my screen, please? Thank you. Can everyone see the volunteer PowerPoint?
No.
No.
There you go.
There we go.
Oh, is that one of the volunteers?
He's a little too young. All right. Briefly go over kind of the goals of the volunteer survey and then where we are right now. Oh, screen sharing has stopped. Sorry about this.
That little gremlin got it, I guess. He's awfully cute, though.
Thanks. 9 months or 8 months yesterday.
Oh my goodness.
Okay, let's try this again. So our survey goals are kind of threefold. We want to assess the degree of satisfaction that volunteers are experiencing, identify any issues or areas of concern to enhance the volunteer experience, and then overall identify a profile of the current Justice Center volunteers. To develop the survey, I used 3 different sources. I spoke with Director Burris and Mary Taylor for their input and context into the situation of volunteers at the Justice Center. And then I also looked at kind of published research, and I found a journal article from the Journal of Offender Rehabilitation that specifically looked at prison volunteers, their profiles, motivations, and satisfaction. And then I also reached out to Multnomah County, which is Portland, Oregon, and they have a pretty robust volunteer program for their county jail, and they recently administered a COVID-19 volunteer survey. So they happily sent me their survey instrument as well. The survey development is divided into 6 categories. There's a volunteer satisfaction piece, volunteers' perception of the environment, a COVID-19 response, discussion of their previous volunteer experience, input for future improvements, and then demographics, where we will look at age, race, ethnicity, tenure or time spent as a volunteer, gender identity, their commute length or how they commute to the jail, and then classes taught. Overall, there's kind of 3 different buckets of the question types. There's 24 Likert scale questions. These are generally asked on a 5-point scale. One example would be 1 is very dissatisfied, and then 5 is completely satisfied with a neutral category in the middle. There's also a few short answer or select from a list. So there's a few yes or no questions. We asked their preferred method of communication, and then the demographics section will likely be a drop down where they can select their race or ethnicity, for example. And then we also wanted to include some qualitative measures. So we have some open-ended where there is no text limitation for their response. Specific 2 examples are, if you no longer volunteer at the Justice Center, could you please describe why? And then also if there's anything else that you would like to share or would like us to know about your volunteer experience. So this will give the volunteer the opportunity to kind of describe anything else that they feel that we need to know, or if we kind of missed anything in our question bank. So in terms of next steps, I'm happy to share a draft. I've already shared a draft with Director Burris and Mary, but I would welcome input from the rest of the board. And if there's any follow-up, my email's on the screen. I will share that I have to hop off immediately after this for another meeting, but I am open to any questions either right now or through email.
Are there any questions?
Bill, could I just give it some context? So,
Yeah, please do.
First of all, I thank Doug and Andrea for their interest in, but for the greater community who might be listening in, there's some context to this, and the board may remember that we had some conversations about a year ago or a little more about the volunteer program and how it was supported or not. So the first thing for everybody to know is the volunteers. I don't speak for the volunteers. I'm just happen to be one of them, and I have, because I'm on the board, I do hear from a lot of volunteers about their experiences. But I think the volunteer program has been just generally ignored, not by the people who are working on it at their best, I think, but it didn't have a full-time effort for quite some time, and it didn't have people running it who know about volunteers. And one of the benefits to this this survey is that both Andrea and I have run have been volunteer coordinators or have run volunteer programs before, so have a general understanding about the care and feeding of volunteers. This isn't, and in the jail, this is not light, fluffy PR stuff people want to be patted on the back, because these are volunteers unlike anything else in the community, I would suggest. These are folks who've come in who mostly do one-on-one with inmates, and they're teaching GED classes, or they're doing Zumba lessons, or they're like me, sitting one-on-one and just listening. But there's lots and lots of people. Many of them are working full-time and still doing this, and they've done this in the face of almost no communication from the jail. I mean, there's no newsletter, there's no regular emails telling us what's going on. There is there's no place to kind of put our concerns, although we have placed them out there, but we haven't really had them resolved. And you guys may remember over a year ago, we talked about the fact that there wasn't even a reliable distribution list, email distribution list. So, my suggestion to Andy and to Doug was, please do not send this out to the list that you think is, that you think is volunteers, unless you have some reliable way of knowing it. We know that in the last several months, there's been an effort to ask all the volunteers to, whether they want to remain active. Oops, sorry about that. Whether they want to remain active. And then they were all people were sent a letter asking if they wanted to remain active and asked to respond by a certain date. And then that subset was sent full applications to reapply, which felt a little bit like the animal services, the pound. And my concern was that not having a reliable email distribution list, we know people didn't get the first, we know people who didn't get the first list who are active volunteers. And we know that there are people who didn't get the full application packet. So I'm glad that, Doug is looking at that whole thing as a big picture, because, this I just want you to know the survey has to be in the context of the larger volunteer program, which, you know, you've heard me say this before, you know, if there are 300 active volunteers, those are 300 members of the community who walk into that jail almost, most of them every week, some of them twice a week. And they have eyes and ears, and they bring with it a big heart, and they haven't always been supported, and they still do it. And so, you know, and it, you know, nobody's looking for it to make their life easier. They're only there to do their class, or they're only there to do their listening, or they're only there to provide a service or do an AA meeting. And that's what they care about, whether or not the service is getting to the inmates. They're an amazing group of people. And I just thought that we should hear their voices, and then we should do things going forward that would support their service, because my sense is if our jail is like every other jail that I know about, we're providing not just hours, but we're providing value added in terms of dollars and classes that you could not replicate, that you could not replace without great cost to you. So that's really, and I thank Doug and Andrea for their responsiveness and for their willingness to listen to me when I go on one of my rants, because this has been a very long process and a long journey with, I felt, no satisfactory responses, even though efforts within the jail, it's fair to say. So that's all I have to say. Thank you, Andrea.
Thank you.
Okay. All right. Thank you, Andrea. Okay. Have a good day. Thank you. Mr. Burris.
Yes, next up is the phone and communications contract. With the increase in numbers of residents here, plus the COVID restrictions that we're placing on people, the current phone and communication system is not meeting our needs. There are things that we can do to, if we get a more modern system, I think it can also help us with having happier residents, for lack of a better term, because it could really expand the family visitation and also allow them access to the law library, which we're required to do. So I did make a request that we start the RFP process for a new communication system. I've been approached by 2 vendors since then, and I've told them, and I'll tell everyone else, that I consider myself under the code of silence because this process has started. And I think we need to just let the process play out. Okay. I'm sorry, Reverend Dwell, I think you might be muted.
Aha. Thank you again. Keep us updated as that process continues to go, just to give us, you know, some idea of any progress as much as you can when you can. But thank you.
All right, thank you.
Our next item.
Okay, programming. This is really twofold. First, we do have a program on cognitive skills training, which for the Cliff Notes version is it teaches people to stop and think before reacting inappropriately. And it's actually part of a program that also teaches resume building and interviewing skills for jobs. It would be taught remotely, and we have an organization that has been recognized by the Department of Labor as a best practice for this. And we'll have to, I can tell you that it's being done in the Troy jail, so obviously if it can happen in Troy, it can happen here. And then why don't you go ahead and explain, Tina, what Tina's in the process of trying to get this set up for when we can implement it.
Good afternoon, Board.
Good afternoon.
You know, Justice Services, we've been fortunate enough to be introduced to the Connections to Success. That's the name of the organization. And this is a nonprofit organization, and they have 3 locations in St. Charles, Kansas City, and they operate here in St. Louis as well. And, you know, they're committed to providing assistance to individuals, helping them to achieve economic stability And the way that they do this is that they break down the systemic barriers that exist among low-income and incarcerated individuals. So not only do they provide the resources, but they also help the individuals to devise a plan to help break that whole cycle of poverty. And so what I found is that the program is unique because they provide services during incarceration and then even after incarceration. And so for our benefit, it looks like the program, their core services include the personal and professional development training program. Before COVID, they apparently did it in person, but now, of course, they're doing it virtually. And bringing it here, hopefully the program is a 60-hour evidence-based curriculum, and it's facilitated by certified trainers, and the program is specifically geared for adults transitioning from incarceration. And it's a very intense program, and what it incorporates is a skill assessment exercise that matches the individual up with the right job, gives them an idea of what job they should look for. And then after that, they also do mock interviews to help prepare them to go out and successfully achieve a job. And with that mock interview, they also will even give them dress clothes. They'll give them a suit that they can take with them after they leave incarceration. They teach them interpersonal communication skills to help them maintain the job even after they get the job. They have a resume workshop, again, that's where they're fitted with those business attire. They're taught how to dress for the interview, and again, they're given a business attire at that time. So, but one aspect of that program that really caught my attention because of something I'd never seen before is a fatherhood training program that they have. And this is a program that they offer to the men, and this training focuses on teaching absentee dads their importance, and it teaches them how to be involved in functioning as fathers in their children's lives. So I thought that was really a good program. And so, ultimately the hope is that with that intensive pre-release training, they're empowering these individuals to leave here with a sense of self-worth and giving them the confidence and critical thinking abilities so that they can continue to be successful once they leave our doors. And so as mentioned earlier, again, they provide services even after the individual is released. They provide whatever wraparound services that the individual needs to continue on to have success and to move positively in positive directions. So they continue to provide them with clothes if needed. They continue to provide them with even transportation to and from job interviews if necessary. They connect them with social services agencies in the community. So, they continue to help this person be successful once they leave our doors. I'm going to attend a virtual training session that they're having in November where they're going to recognize some of their success stories and where they're going to highlight some of their achievements. And beyond that, I've already reached out to them and trying to begin conversations on seeing what we could bring here to our facility, what services that we could provide here to our inmates. And, the last thing is I would encourage you to go to look at their website. Connection to Success is a very, very impressive, very interactive website, very, informative, and I was truly impressed with the website, and I'm thankful, to have been introduced to them and looking forward to working with them and bringing them in here.
Thank you, Tina. And I'd like to add to that just real quick that they have business leaders who hire people that have criminal records do some of the mock interviews. So that is a great option. And of course, what I'm about to share, they don't do with everyone they serve, but they do have a program also where they take donated vehicles, and to some of their people that are in need of a vehicle, they will take care of the insurance and maintenance of that vehicle until the person is stabilized, then give them the title to the vehicle. They've done this over 200 times. I personally have donated 2 vehicles to them for this program.
Very well. Mr. Smith.
Thank you, Reverend Duvall. And yeah, thank you for the presentation. I just wanted to say I've worked with Connections in a couple different capacities, have been so impressed with their staff work and their leadership. I've seen independent studies validating their success in reducing the likelihood of recidivism. The federal government has recognized, that with grants and awards. So I couldn't be happier with your selection of them as a partner. So thank you.
Thank you.
Okay. Anything else, Mr. Burris?
Yeah, just real quickly, this is more just an initial FYI. We are looking at how we're doing staff shift changes and the impact it has on overtime and even forced overtime. And I'll be able to give a more lengthy report on that at the next meeting.
Very well. Do we have any items to discuss under new business?
Real quickly, Reverend, when I was up here the other evening, I saw someone discharged slightly before 11 o'clock at night into the cold when it was 42 degrees out. We do not have any coats to give these people, so we will be doing a coat drive, and we'll be sending out information on that soon, but we really needed to get this going because my understanding is we even have possible snow next week.
Wow. Okay. Okay. So we look forward to that. You'll give us the details as soon as possible.
Yes.
Okay. Thank you.
Phil,
Yes, ma'am.
is our link going to expire at 11?
Yeah, it'll continue for about a half hour.
Oh, okay. I do have something under new business if nobody, Spring, I'm sorry, go ahead.
No, go ahead, Mary. You can go first.
Well, I just want to have a little bit of a discussion about something that I think, again, we've kind of stepped over a little bit, and that is on August 26th, I sent an email to Reverend Duval, the executive and the chairwoman of the council, asking for an independent external investigation in response to allegations and testimonials about corruption and abuse at the jail. And the Post-Dispatch reported it, and the county executive said he supported that. 8 weeks ago at our board meeting, we made a recommendation. I think Jeff made the motion. We made a recommendation to the county executive and the council that the investigation should occur, stated our reasons for that recommendation on the record, and to the county executive. And then we met several times with the county council committee on justice, welfare, and safety. I think I have that right. The county executive pretty quickly asked us to submit a description of this, what we considered to be the scope of the investigation. And we did so right away after referring to all the information that had been sent to us and by current and former staff in the community, and from our own experience on the board. And we asked for a meeting in person to present it. 7 weeks ago, on September 3rd, 3 of us did meet with the county executive, some of his executive staff, and 2 council members. And during that meeting, I mean, interestingly enough, we really didn't discuss the scope of the scope document, but the county executive told us he anticipated hiring a consultant to develop the scope and an RFP, and assured us that we would have input. We expressed our concerns for the safety of some of the whistleblowers who had been threatened, and also asked for more open communication so that this request wouldn't fall into a black hole and disappear. And I guess the reason I'm talking today is because I feel like there may be work behind the scenes, but we certainly haven't heard anything about it. Well, I think that kind of has happened. So the board, we've fallen back into old patterns of no communication with this board. And I think this board has been very active. I don't know about the other citizen boards, but from my experience in other places, we've been very active. We spent lots of hours listening to staff and former staff, developing the scope, attending council committee meetings, and responding to council members who have reached out and talked to us. And direct and ongoing communication from the county executive seems to be the very least we might expect as a respectful response to our efforts as community representatives. 1 month ago at our board meeting, I brought this up again, although not at such length. And I asked for follow-up, and I think there was no representative of the county executive because they generally don't attend on, at least as panelists. And but Beth was there. Poor Beth Orrick. She got it from me, and I asked Beth if she would follow up, and we haven't had any follow-up on that request either. So I sit here today, 8 weeks out, about something we thought was pretty urgent, without the board hearing anything about our recommendation, which has since been affirmed by the County Council Committee on Justice, Health, and Safety. So today, I really feel that, you know, I can't just have to do something. And I would like to offer a motion that the County Executive Office provide to the Justice Service Advisory Board a detailed update as to their efforts to obtain an external investigation, and further designate someone in that office as a delegee of the county executive with a timeline for accomplishing that which the board recommended and the County Council Committee on Justice, Health, and Safety affirmed. So that's my motion, those two things.
Chair, may I be recognized?
Yes, Ms. Orwick, please.
Thank you. Thank you, Ms. Taylor. I did follow up as you asked. I thought it would be inappropriate to address, not in a public setting. I would not want to talk to all of the board members because this is not necessarily a legal update. But I did talk to Dr. Page about this, and he did ask me to speak about this if asked at the meeting today. So that's what I'll do now. You're worried that it has fallen into a black hole, like your concerns are being waylaid. I just want to assure the board and you, Ms. Taylor, that that's not happened. As you know, there is a legal investigation, personnel investigation going on right now. It is ongoing, and it would be completely inappropriate for me to speak on that. But you know that that is ongoing. While that is ongoing, Dr. Page has decided that there will be no details on the second investigation or the more global investigation, as you gave a scope for, until that first one is done. But he does expect to take a deeper dive. It's just not the appropriate time right now, as that first investigation is ongoing. I thought that was important to share with you as you did bring up your motion, and I did want to give you that information.
Thanks, Beth. I hear what you're saying. I guess I just thought my motion still stands for ongoing, because I don't think you are necessarily the appropriate go-between. My understanding was that the personnel legal investigation was through the county counselor's office and was work product and
correct,
and quite separate. I didn't realize, nor do I still know, whether these were concurrent or I didn't know that one needed to follow the other. And that would have been nice information for us to have from the county executive's office. And I don't know if that's Mr. Chapman or if that's someone else, but I think given our response to the county executive, given the time we put into place, I think we could turn over a new leaf by having clearer communication from the county executive's office, because when we met with the county council, they really didn't know anything about any of this background or any of these things, and they aren't the appropriate place to go, and you really aren't the appropriate place to go. So the only appropriate place to go is the county executive's office, and we seem to have I know that there are members of the board who may have informal conversations with the county executive, but as far as I'm concerned, that's not good enough. We have done things as a board, and I think we deserve to be communicated to as a board, and so my motion still stands.
Does anybody like on the board, Jeff, Dr. McBride, any comments to move this motion forward?
I support Mary's effort, and I'll leave it at that.
Reverend Duvall, it's been a few minutes now since I heard the motion, so in hearing what we heard about the update, does the motion call for us to get a report at the next meeting, or what is it? What did you say again, Mary, in your motion?
No, but that's a terrific idea. No,
Yeah, and that's why I'm sitting here wondering what I should do on the motion to second it or move it or whatever.
That the county executive office provide to the Justice Service Advisory Board for the next meeting and ongoing regular communications regarding the update of the external investigation. And number two, that a delegee from the county executive's office be identified as the point person for that ongoing investigation. Because it's not going to be Mr. Burris, and it's not going to be the county counselor's office. It's going to, if there is going to be an investigation, there's going to be someone we're going to need to talk to. So if you need me to separate those out, that's fine, but I think they're perfectly fine together.
So I'd like to second the motion and suggest that we add as a friendly amendment that there'll be updates provided to the, as we just discussed, to the extent possible, something like that, or if that's just if that's inherent, given what the counselor said, there's only so much that can be said, but it would be worth just getting a regular report.
Okay, well, it's been moved and second. Ready, roll call for a vote, please.
Reverend Duvall,
Yes.
Dr. McBride,
Yes.
Dr. Smith, Mr. Smith,
Yes.
Ms. Schmidt,
Yes.
and that's it.
Okay, thank you, Mary.
And I say yes.
Mary says yes, Mary Taylor.
Oh, thank you, Mary.
Any other new business? Again, I just want to make sure that it's added on at the top of the agenda, that we elect a new chair who can forward these motions in the business with some continuity. Please make note of that will be on the agenda next month.
Reverend, can I ask something for you, sir?
Yes, please.
I know that this is a job responsibility that you have taken very seriously and have helped in a lot of external conversations and side conversations and community conversations and many other things. We are extremely happy that you agreed to stay on the board, but you announced your resignation and asked this board for some relief and some grace from the weight of the role of chair. My understanding from what Mr. Capizzi said earlier is that other people can help fill in roles and they're required to be the chair in the next 30 days. We didn't get this on the agenda and we should have to be responsive to your request. But if you are asking us to also help take on additional roles in the next 30 days until we get this replaced, we should answer to that. And I, for one, will do that, or anyone else would.
I appreciate that, Spring, and I would like to separate. I'm not able to continue in this capacity, and I would prefer not to hold on. So if there's anybody who would be willing to facilitate the meetings, and I'll try to make myself available to be in the meetings, but at a very limited role. So thank you, Spring, and yes, I would like some formality as to what we're getting ready to do going forward.
Hi, Reverend Duvall.
Yes, sir.
Yeah, insofar as you have certainly taken the lead on facilitating, conversations in between meetings, between corrections staff and board members and move the ball forward on innumerable matters, in between meetings, I'd be happy to, step up and be helpful in the next month.
Thank you, sir.
Reverend Duvall, if I could.
Yes.
Yeah, and I appreciate that, Jeff. And I want to second Spring Schmidt's comments that given that you've said that you want to step aside and, I think there are things that crop up in between meetings. We've all seen that, and it's a lot of effort has been expended, and I don't think the public always realizes that. So thank you, Jeff Smith, for doing that. And I would, let me just say it again because you just stepped back. Thank you, Jeff Stiff, for doing that. So I think it's important that somebody take that role in the next 30 days or so, and that you don't have to jump in the next 30 days. So
I appreciate that.
I think this lets us honor both the concern for the fairness of the sunshine piece of this, but also what you expressed to us last month and the grace that you asked us for. And we're so grateful for you to stay on in this role. I wanted to make sure that that was something that the board honored. So I'm very pleased with this arrangement, and I hope that that works.
Thank you. Thank you. Are there any? Thank you, Jeff. Thank you, Tim. And again, thank you, Spring. Would like to, were there any community comments? Anything submitted for discussion?
Not this time, no.
Nothing, sir.
All right. So, Mr. Burris, before we set the next time, is there any closing comments you'd like to have, sir?
I'd like to say I appreciate the communication I've had from the advisory board, and the staff here has overall responded very well. I do think we are building the foundation for an excellent facility here.
Thank you. And again, welcome aboard. Jeff, could you please, let's set the next meeting?
Yeah, my calendar. I guess the 4th. Well, we don't want to do it. The 4th Friday would be the Friday of Thanksgiving, and we don't want to do that. So we could either move it up to the 3rd Friday, which would be the 20th, or we could do the 1st Friday of December, which would be the 4th. Is there a preference?
I think earlier gives us more urgency to put some things in place that we need to. So the 20th would be my vote.
Okay.
I can, just speaking up, I'm sorry, for the board, I have conflicts. I apologize for on both the 20th and the 4th. Stepping in, I might be able to be there for part of the 4th, but so you're saying you want to do the 20th?
If the 4th is better, hold on. No, I can't do the 4th. I'm sorry. We always have trouble with this when we move it from the 4th to the 4th Sunday, don't we?
So I think we may have problems with quorum. I have a conflict on the 4th, but I'm not sure with, because we currently have 3 members not here today, 2 members not here today.
We barely got quorum.
Yep.
Can we set it tentatively for the 20th?
I'm good with that.
And if we need to, we can poll, maybe Jeff can poll the members and see who can be there. And, we're just going to, no matter which one we choose, somebody's going to be missing. It sounds like.
Yep.
I'm
okay with that.
Yeah, we can ask people to hold the.
Okay. Well, again, thank you, everyone. And the next meeting is tentatively set for November 20th. Jeff, you and I, send out that email, get the consensus. Thank you, everyone. And again, Spring, thank you for taking this back up. And look forward to seeing everybody next month. Thank you, Mr. Burris.
You want a motion to adjourn?
Yes, thank you, Mary. I'm
Second.
really. The meeting is adjourned. Thank you.